Alright, my name is Essen Niazi, and I will be talking to you about NewGen chronic care physicians. So some background on the state of primary care. Currently it's viewed as economically unfavorable. Less than a third of PCP physicians accept Medicare. Medicare reimbursements are set to reset at the end of 2015 to pre-ACA levels, at which point the rates will be drastically cut. Currently they're about, I think, 76% above what they were last year, and so that's about half of the money you would receive for PCP procedures cut right up front. This will also cause a shift towards, so there's also a shift occurring towards value-based medicine, and it's causing an exit from the industry because now physician compensation will be tied to patient outcomes, which frankly physicians don't feel they have a strong degree of control over. You know, they can make suggestions, but they really can't enforce them. So this is really putting a lot of what you could say risk management on the physician's plate for a subset of patients where they're already receiving a relatively low amount of money than they are from the private market. So as stated previously, value-based medicine is tying physician income to patient outcomes, and the incentive is if you save the money for insurers, they'll pass on the savings to physicians. You know, that remains to be seen. Outcomes are hard to control, and measures, the quality measures that are measuring, you know, whether an outcome is positive or negative, are oftentimes confusing and constantly changing. So adapting to this new landscape, adapting to the VBM and ACA has flooded the healthcare market with new enrollees. It's a big market of untapped, what are viewed as less valuable patients. And this is expected to create a surge in demand for primary care services. Retiring baby boomers will also increase the demand for primary care physicians. And VBM emphasizes on prevention inherently involve the services of primary care physicians. Now, the rise of retail, with the market pressures, you know, the way they are currently, and the demand so high and the supply so low of primary care services, retail clinics have proven to be a disruptive business model to the industry. What this means is they've basically broken into the industry through a back door where PAs work in what is essentially a big closet in CVS, and they have prescriptive authority under operational contracts with physicians that CVS or whoever has signed, or some independent. Basically, they have contracts with CVS to provide prescriptive authority to the PAs working there, allowing them to prescribe Schedule 2 and below medications. Now, this has kind of stolen a lot of market share from PCPs, and there's a lot of resentment there. And aside from just the economic incentive, they say that there's a lower quality of care provided, and it disrupts the continuity of care because these clinics, these minute clinics, these ready clinics, retail clinics, do not keep EHR, and they do not accept Medicare. So even, you know, some proponents will say that, oh, they're adding to the accessibility. Well, no, they're really not, because they're not addressing the demographics that have the most difficult time with accessibility. So some of the positives of this business model: they have a narrow scope of activities with mid-level practitioner use, and this is proven very cost effective for them. They have a list of conditions that they can treat very quickly, and they do so very efficiently, and this is, you know, provides a lot of value to patients. They come in there, they get out quickly, it's no hassle, and their insurance may cover it, may not. Either way, they pay some cash, get in, get out, and they go on with their life. So NewGen Chronic Care Physicians was born out of an idea to reconcile the strengths and weaknesses of retail clinics and primary care physicians. The ideal function is to provide fast, convenient, and cost-effective care by narrowing the scope of activities to address chronic disease subsets. It also seeks to position itself to capture new healthcare beneficiaries through innovative business models and capture the demographic that other providers view as not economically favorable, or undesirable, or just a hassle to deal with. So some pertinent issues. Uh, More healthcare beneficiaries means longer wait times in traditional points of care, outcome-based medicine, value-based medicine, and meaningful use of EHR and PQRS standards. PQRS standards stands for Physician Quality Ratings System. So basically, they'll identify certain measures. They Center for Medicare and Medicaid Services and the National Quality Foundation, or whatever they're called, will identify some metrics that correspond to outcomes, and they'll say, okay, this metric judges this outcome for this disease set. So it'll be up to the physicians to bring their patients above or at that designated quality standard and the threshold for it. If it's above, they'll get paid more. That'll be seen as added value care, value-based medicine. It'll add value to the care of the patient relative to the population, and the patient will be compensated for that effectively. Conversely, if they're below that mark, then their rates will get slashed already. So essentially, physicians are being penalized for treating patients, sicker patients, by some standards, who do not have the same prognosis or ability to have better outcomes compared to other people in the population. So in industry analysis, you have 5 forces. The power of suppliers is pretty high, but there's no chance of forward integration, so that's neutral. From below, you have the power of buyers. Private and public insurers have huge negotiating power. If you can provide value, I think, though, they will be willing to negotiate with you, but you have to be able to prove that you can provide the best bang for the buck that they're willing to pay. The threat of substitutes is pretty high. Retail clinics are gaining share over traditional medical homes, but they have limited capabilities, so that's neutral also. Barriers to entry are pretty favorable. There's a high amount of capital investment necessary to break into medicine. Medium customer loyalty, if people go somewhere, they generally tend to keep going there just because it's easier and they've been there before. There's high switching costs for them. If they go somewhere else, they have to fill out the form and yada yada yada. It's just a headache. Scarcity of qualified human resources. In general, there is a shortage of primary care physicians, and that will worsen as time goes on, with the view that primary care is not cost effective from the perspective of a medical student. More and more students are specializing and choosing not to pursue primary care, and those that are likely not to accept Medicaid. So NewGen Chronic Care, what does it offer? It offers 2 solution sets, low activity segments with high throughput in the short run. So basically, we want to take patients that we can treat easily and quickly with chronic conditions that do not require a lot of maintenance. They're really just there to say hi, hello, get a prescription refill, and be out the door. They really don't want to speak to you. There will be always a subset of patients who do, but the vast majority of them just want to get in and out as quickly as possible. So those are activities, core competencies geared specifically towards them. The high activity segments with better outcomes, this is geared towards longer growth in the long term. So this is really tapping into those Medicare beneficiaries affected by multiple conditions, chronic conditions, that the reimbursement will be based on quality measures that CMS or NQF establishes. So the idea there is we identify a set of patients in the private payer population, develop a set of management protocols for those diseases, or for that specific disease, and then apply that protocol to the public payer segment, and hopefully it'll transfer over. So the tools needed: telemedicine to deliver convenient and cost-effective care, innovative data collection and monitoring systems for trend analysis and quality outcome measures. There's also HIT system requirements, health information technology requirements, to specifically interface with ER, track meaningful use, and record PQRS metrics. So some difficulties. Finding the minimum efficient scale to employ economies of scale will be a difficult task. Developing management protocol which is effective in private and public payer demographics. We're not sure if it'll transfer over. I'm certainly not sure if it'll transfer over. There are huge disparities between the 2 demographics. Brand building with a restricted patient subset. If you're only treating a certain amount of diseases, it might be difficult to build a brand, but it won't be impossible. And that's it.